A treatment with positive expected outcome does not prevent individual patient deterioration. Expected value describes average behavior across a population. It says nothing about the individual path that crosses a clinical failure threshold. A single acute event can push a patient into an irreversible state. Once that threshold is crossed, the expected treatment response becomes irrelevant. Averages do not prevent absorption. Individual patient survival requires more than a favorable population mean. Brain death, multiorgan failure, and permanent disability are clinical absorbing states. Once reached, the patient cannot exit. All future treatment responses become irrelevant after absorption. The tail of the deterioration distribution governs exposure to these states. Rare but catastrophic deterioration events dominate long-run absorbing state probability. The average clinical trajectory does not characterize individual ruin risk. Tail events define clinical irreversibility. A patient with limited physiological reserve behaves like a finite random walk. Failure occurs when reserve reaches zero. Even with a positive mean treatment response, ruin probability is strictly positive. Initial reserve determines how long the patient can sustain adverse physiological sequences. Small reserve means the patient cannot survive the same perturbations a robust patient can. Physiological survival is a question of path, not of expected treatment effect. Limited capacity defines the absorbing boundary. In a healthy patient, physiological deviations decay rapidly. In a frail patient, the tail of the deterioration distribution decays slowly. Extreme physiological events remain significant for much longer in frail patients. Standard deviation of clinical markers may be finite while absorbing state risk is poorly characterized. Tail shape of the deterioration distribution governs ruin exposure, not average clinical variance. A short clinical observation window cannot reveal long-run deterioration probability. Over a short horizon, ruin probability depends on initial reserve and physiological stress distribution. Over a long horizon, a frail patient's ruin probability approaches certainty. Positive short-term treatment response reduces deterioration probability. It does not eliminate it. Time increases exposure to physiological absorbing states. It does not provide protection. Expected treatment outcome does not predict whether an individual patient crosses an absorbing state boundary. Survival analysis is structurally different from mean-based clinical reasoning. A favorable population average does not imply individual patient safety. Low clinical variance does not imply low absorbing state risk. In frail patients, even small deviations from equilibrium may trigger irreversible deterioration. Mean-based clinical metrics are structurally blind to absorbing states. Survival analysis addresses what averages cannot.